Thank you, Ray, and thank you for the organizers for inviting me to give this talk today on assessing organ response in AL and TTR amyloidosis, evolving concepts. I think I joined Steph in saying that this topic has been given to me because there is not a lot of supportive data, and it is really an evolving and difficult, challenging topic, especially in TTR. So I'll start with a case presentation of 46-year-old male was diagnosed with AL amyloidosis in October of 2012 after presenting with cough and fatigue. Initially, he was treated for bronchitis, but then developed lower extremity edema and was eventually sent for an echo, which showed increased salvia wall thickness, global hypokinesis without distinct wall motion abnormalities, and he underwent a cardiac catheterization showing normal coronary arteries, a decreased ejection fraction, and high LV filling pressures. Fortunately for him, he developed acute abdominal pain, which led to a colonoscopy, and random biopsies of the colon showed a Congo red positive amorphous material with apple-green birefringence consistent with amyloid, and that was how he ultimately was recognized to have this disease. He was sent to a hematologist, and initial studies showed an elevated free lambda light chain, elevated NT-proBNP and troponin. So ultimately, he was diagnosed with Mayo cardiac stage 3A, revised Mayo stage 4, and had New York Heart Association class 2 heart failure. He was treated with Cybor-D for 7 cycles and achieved a hematologic CR, but developed painful, debilitating neuropathy, and his NT-proBNP remained elevated over 3,000. He sought care. He sought other options, and he actually found us and was enrolled on the phase 1/2 trial of the antifibrillar agent NEOD-001 that Ray just told you about. When he came to us, he was about 10 months after achieving a CR. On the x-axis is the percentage change in NT-proBNP versus time, and at CR, his NT-proBNP remained over 3,000. It was almost about that at the time he enrolled in the clinical trial. He was on the phase 1 portion, and his NT-proBNP started to trend down. When the recommended phase 2 dose of 24 milligrams per kilogram was defined, all patients were changed from the phase 1 portion to the phase 2 portion and offered this dose, and he continued to have an NT-proBNP response. My slide of my questions did not come up, but my question about this case to the audience is, so what was the reason for his improvement in his organ function? Number 1, was it his achievement of a complete hematologic response due to Cybor-D? Was it 2, the antifibrillar antibody NEOD-001? 3, was it going to a doctor and getting put on who understood amyloid and getting put on diuretics rather than beta blockers? Or 4, all of the above? And I think I'll leave you with that question while I continue the talk. So as we know, AL amyloidosis, the pathogenesis is because of a dangerous small B-cell clone that produces the immunoglobulin, the heavy chain and light chain, and it's these light chains that Ray just told you about that are either kinetically or thermodynamically unstable, and due to cellular and extracellular interactions form these amyloid fibrils and disrupt organ structure and function. And we do know that different germline gene usage predicts different organ tropisms, but the most important determinant of survival is having cardiac involvement. So we know that light chains from patients with AL cardiomyopathy induce MAP kinase signaling and increase production of reactive oxygen species, impair calcium homeostasis, and this is what leads to eventual cardiomyocyte death. We also know that MAP kinase signaling is responsible for transcription of the B natriuretic peptide, and this shows a direct link between the toxic light chains that cause cardiomyopathy, MAP kinase signaling, and elevated BNP in this disease. And it's not surprising that both BNP and NT-proBNP are prognostic markers in AL, and troponin, which is also a marker of cardiomyocyte death, also independently is associated with survival. And the initial cardiac staging system based on NT-proBNP and troponin devised by the Mayo Group, which was further revised by the UK researchers, which better discriminate outcomes in the highest risk patients, is the most useful, most commonly used staging system, both in clinical trials and in clinical practice. And the figure on the left shows data from about over 1,000 patients from PAVIA, discriminating the patients' differing survivals based on this staging system, whereas the figure on the right shows data from over 900 patients from the UK group. And what can we say about this? Maybe we can say that Ashu treats his patients better than Giovanni and Giampaolo does, or we can just appreciate that actually the figure on the right is from a more contemporary cohort where there is access to more and emerging therapies that we've already heard about this morning. But we can also appreciate that our stage 3B patients over time in this contemporary cohort, the outcomes have not changed for these patients, and our most advanced patients, our sickest patients, are not benefiting from any of these emerging therapies. We're also grateful to Dr. Sancharawala for developing the BU staging system, which is based on both BNP and troponin, because not all centers have access to NT-proBNP, and this is an important staging system. And we can also understand that the clonal burden of disease as defined in the revised Mayo staging system, as assessed by the serum-free light chain assay, or the difference in the serum-free light chains, which was incorporated because it's also an independent prognostic feature, is also useful to define our patient population. We have emerging technology, or we have appreciated that 2D global longitudinal strain, which is a very sensitive technique for measurement for it not only is important for diagnosing patients with amyloidosis, but also predicts survival in transplant and non-transplant patients. But it has to be appreciated that there's different platforms for analyzing strain, and these cut points and these survival differences really need to be interpreted within a context. We have a staging system for patients with kidney involvement who are at risk for developing end-stage renal disease, as we heard from Dr. Sancharawala, and based on the 24-hour urine total protein and GFR values. And patients with stage 1 disease really have a low likelihood of requiring dialysis, but our stage 3 patients have a 50% risk of requiring dialysis at just 2 years. How do we treat the disease and improve organ function? Right now, all of our therapies have been, to date, directed at the plasma cell, and with elimination of the pathologic plasma cell, we see reduction in the free light chains, and when we achieve hematologic response, organs can improve, as indicated by the biomarkers that define the organs. And if we achieve a hematologic response, we can prolong survival. But if we achieve also an organ response, we improve that significantly more. We are fortunate to have validated criteria for assessing hematologic and organ responses in cardiac and renal patients. So hematologic response is based on the serum free light chain assay, and we're grateful that the low DFLC response has been initially studied in patients who didn't have measurable disease and predicts for a better outcome in this group of patients. We also have validated criteria for assessing cardiac response, which predicts overall survival, and renal responses, which predict for renal survival. Have to appreciate that we don't have any validated criteria for hematologic progression in this disease. So we don't know, and it has never been studied, at what level of free light chain causes organ progression. However, we do think that minimal assessment of minimal residual disease will be a critical factor for understanding the risk of organ deterioration and also for organ response. And these data from the Pavia group in 69 patients have shown that patients who achieved a MRD negative disease by next generation flow cytometry have a higher likelihood of achieving an organ response. However, this relies on bone marrow testing and assessing the plasma cells, and it is likely that detecting minimal residual disease by clonotypic light chains in serum or urine will be more useful in this disease as opposed to bone marrow-based testing, which has been useful in multiple myeloma. And indeed, Dr. Dispenzieri has shown that in 53 patients that at complete response by IFE, free light chain, and 6-color flow cytometry, 4 of the patients were still positive for the original clone by mass spec-based technology in serum. And I call your attention to Dr. Sharpley's presentation on Monday, which also shows mass spec techniques can be really sensitive for detecting residual disease in this in AL amyloidosis. While mass spec techniques are not yet ready for prime time, we have heard the value of reduction in the DFLC to less than 1 milligram per deciliter, initially studied again in patients with a low free light chain burden, and gives us a tool for measuring responses in this patient population with favorable overall and renal survival. And in over 900 patients We're now fortunate to know that in 900 patients treated with bortezomib-based therapies, independent of whether they had low free light chain burden or measurable disease, a reduction in the DFLC to less than 1 milligram per deciliter was associated significantly better overall survival, time to next therapy, and progression-free survival, and even increase the frequency of cardiac responses. Again, I'll bring your attention to an abstract from Dr. Purvey showing the value of achieving a prompt DFLC less than 1 milligram per deciliter, which predicts for early renal responses, and and as well as the other data from Dr. Comendo's group that will be presented at the similar session. We also have retrospective data dividing responses for organs based on 4 categories, a less than a 30% that have been published, less than 30% reduction in these parameters, NT-proBNP, proteinuria, or alkaline phosphatase in patients with hepatic disease, constitute no organ response, a 31 to 60% reduction, or a partial organ response, and greater than 60% reduction as a deep organ response, and below a certain threshold as defined by these investigators as a complete organ response. And these authors have shown that grading the depth of organ response is a better discriminator of patient outcomes, and we look forward to an international effort to validate these findings, which is currently ongoing. GLS, which we've heard about this morning, is a good predictor of overall survival when looking at baseline characteristics, but it has also been studied by several groups over time, and serial values from our group in 34 patients with advanced stage of amyloid has shown that patients who have a hematologic CR can have improved GLS, which is really our first functional measurement that has been appreciated in our. This is 34 patients who 9 of whom had achieved a CR following transplant, and not unexpectedly, the BNP has decreased, the troponin has decreased, but this was our first cohort that showed that the GLS can actually improve, which is distinct from patients who did not achieve a CR. In summary, assessing organ response in AL amyloidosis is achieving an organ response in AL amyloidosis is unlikely to occur in the absence of a hematologic response, and is definitely dependent on the depth of hematologic response. We also have to appreciate that organ responses evolve over time, and I'll show you a scenario where this is important. Historically, our organ responses have been based on cardiac biomarkers and 24-hour urine protein excretion, but we're looking forward to new information on refined depth of organ response, which will likely be better discriminate patient outcomes. We also are looking forward to more data on echo parameters such as global longitudinal strain. I didn't speak about MRI characteristics, which we do know, again, can be prognostic as baseline criteria, but haven't really been studied in any robust way over time. Other imaging that may come to the forefront is floor beta pure PET, which is a much more sensitive test of amyloid load. One question that I'll ask is, will the same biomarkers apply with the use of fibril-directed therapies? And I think that incorporating these into the studies that are upcoming will be very important. I'm moving on to transthyretin amyloid. Dr. Comenzo explained that transthyretin is produced by the liver. It circulates as a tetramer, but it's when these dissociate and the monomers misfold and become misfold into amyloidogenic, into amyloid fibrils and deposit in the heart and the nerves, that patients get sick with this disease in both the wild type and hereditary versions. Fortunately, we do have some staging systems, as in 2016, Dr. Grogan published a staging system based on troponin and NT-proBNP, which can discriminate patient outcomes, and in wild type TTR. And in 2017, the UK group published a staging system based on NT-proBNP and GFR in both wild type and hereditary cardiomyopathy patients. And but we have to understand that although these these biomarkers are useful and are being incorporated into clinical trials in wild type and wild type and hereditary TTR trials, there's really limited data for validating their use for either response or progression in these diseases. Serum transthyretin has been studied as a prognostic indicator in wild type TTR in over 100 patients, and a low value of TTR below 18 milligrams per deciliter versus a higher value was predictive of overall survival in this small cohort. And these investigators showed that in a small number of patients who were treated with diflunisal, the stabilizing agent, the serum transthyretin could increase. And the authors suggested that this may be useful as in order to determine as a determinant of organ response or progression. However, with the use of RNA silencers, as Dr. Comenzo just alluded to, that serum transthyretin, the role of serum transthyretin will be evolving and probably not useful in that cohort with that therapy. So assessing organ response in TTR is really a black box. In the absence of available therapies, there really has been limited data characterizing organ responses in this disease. There's emerging disease-modifying therapies for TTR, and with the introduction of these therapies, there's really a critical need to study these biomarkers as surrogate endpoints in research and to guide treatment efficacy in clinical practice. Going back to our case presentation of our gentleman who achieved a complete hematologic response but still had elevated cardiac biomarkers, we look at his assessment of treatment response. Pre-treatment, he had an NT-proBNP of 3,000, over 3,000. Post-treatment, this has improved considerably, and he has achieved a documented organ response. He also has had an decrease in his ventricular septal diameter, an improvement in his ejection fraction, and a marked improvement in his GLS. That being said, answer to the question whether or not this is because of achieving a complete hematologic response, because of receiving antifibrillar antibody therapy, because of being put on diuretics, or all of the above. I still don't have the answer to that question. One last concept I think is important when talking about organ responses is that organ responses evolve over time. Here we see a patient whose free lambda is on the x-axis. Free lambda is shown here, and this is a patient who in 2008 underwent a stem cell transplant. You can see that unfortunately she had no response to her stem cell, no hematologic response to her stem cell transplant, but after BD consolidation, 6 doses, she achieved a prompt hematologic response, but of course developed debilitating neuropathy as we were giving IV bortezomib at that time. And in 2019, she has not received any other treatment and has remained in a complete hematologic remission. At baseline, she had 21 grams of proteinuria. And what you can see here is she achieved a complete hematologic response in 2008. It really takes a long time for organs to improve. She achieved a level of less than 1 gram. Again, she had her hematologic response in 2008, and it wasn't until 2014 till she achieved a urine protein excretion less than 1 gram. And in 2019, it is no longer detectable. And what you could also appreciate is her serum albumin level, which was in the 1 range when she was diagnosed, took 4 years to become normal. So the conundrum is you achieve a hematologic response, but you still have this very high urine total protein. And oftentimes I see patients who are continuing to get further therapy, even despite getting side effects from therapy because this organ biomarker has not improved. And sometimes it just takes a little patience. Hopefully with antifibrillar therapy and the studies that are going on planned by Dr. Lynch and Kalem Biosciences will help speed organ recovery. But again, I think right now assessing organ response with those therapies is still really a black box. I thank you for your attention. Coming to New York, visit us in our new building. I really want to thank the organizers, Jeff, the amount of work that Jeff and Silva particularly have done to make this symposium available to all of, not only all of you, but all of the doctors and patients and interested parties outside of this room. Is really commendable. And we really, I want to thank not only my colleagues and collaborators at MSK, all of my collaborators here on the podium, and really the amyloid community, which is really a very tight-knit community, all working towards the common goal of identifying these patients earlier, getting them treated, and really stopping the progression of this disease.